Hi everybody, and thanks so much for coming today. It's a real pleasure to be able to talk to you about something that I'm very passionate about. I really have great concern for women's quality of life, especially with a history of cancer when they're being treated for cancer. So it's exciting for me to be able to come and talk to you today. I just want to mention a little bit about my clinic. It's the Women's Wellness Clinic, and I see patients both here in Detroit and in Farmington Hills. And our clinic focuses on seeing patients with a new breast problem and take patients all the way from diagnostic evaluation, sometimes even including biopsy, to diagnosis, and then referring patients if they do need actual cancer treatments. We also see and care for patients with benign breast problems such as breast abscesses, nipple discharge, breast pain. We also care for breast cancer survivors. We care for patients who are at elevated risk for breast cancer and provide a comprehensive risk assessment as to whether or not they actually have a risk for cancer, and if they do, what they can do to help reduce that risk. And finally, one of the things I also do through my clinic is care for women's menopause concerns and sexual health issues. So that's why today we're going to be talking about sexual health and cancer. So I just want to ask first, from your experience, has your sexual health been affected from cancer? And if so, how has your sexual health been affected? Have you talked to anyone about these concerns, and would you like to talk to someone about these concerns to improve your quality of life? So just at a glance, sexual health, with regard to sexual health, the two most common sexual health concerns for women of all ages, whether they've had a history of cancer, cancer treatment or not, is pain with penetration due to vaginal dryness and atrophy, and decreased desire or lack of interest in sexual activity. Just to keep in mind, certain treatments for cancer can make some of these problems even worse. Now, one of the things that can happen to women after menopause, when the estrogen levels reduce, or as a result of cancer treatments and therapies that will cause estrogen levels to reduce, is called vaginal atrophy. And vaginal atrophy is an actual physiologic change that can happen to women's vagina. It involves the thinning of vaginal tissues, narrowed vaginal opening. The cells in the vagina actually change from a normal, healthy vaginal epithelium, which produces lubrication and provides elasticity. Several layers down are cells called peribasal cells. And with vaginal atrophy, the peribasal cells actually become the dominant top cells in the vagina, which causes a lot of problems for women, such as pain, decreased lubrication, decreased elasticity, and interestingly as well, the pH of the vagina can change. Normal vaginal pH is 3.8 to 4.5. With vaginal atrophy, we frequently see the pH increase all the way up to 5.0 and higher. This can be a real problem for women with regard to preserving the normal flora or the normal acid-base bacterial balance of the vagina. If the vagina is too basic, the bacteria that we don't want to overgrow can overgrow, and that's when women may experience increased frequency of bladder infections, such as 3 or 4 bladder infections a year. So sometimes when women may not actually be sexually active and know that they have some vaginal dryness or tenderness, they may actually instead have frequent bladder infections, and this could be the cause if they have vaginal atrophy. So overall, like I mentioned, it's caused by the decreased levels of estrogen in the body, specifically affecting the vagina. And the things that can cause this with relation to cancer treatments are chemotherapy, surgery to remove the ovaries, radiation to the pelvic floor, anything that really disrupts ovarian function to be able to produce estrogen can cause vaginal atrophy. So the therapies that we have available for vaginal atrophy, first of all, make sure you are moisturizing and lubricating. And what women may not realize is vaginal moisturizers are different than vaginal lubricants, which are to be used with sexual activity and penetration. Vaginal moisturizers are actually to be used on a regular basis, about every 3 to 4 days. And what they do is they actually provide a moisture barrier and hold about 60% more water to the lining of the vagina and the vaginal epithelium. Vaginal moisturizers like Lubina and Replens are available over the counter. They don't cure vaginal dryness, but they can help with the symptoms. And they don't cure vaginal atrophy, but again, they can help with the symptoms and the discomfort associated with having vaginal dryness. They can sometimes restore the natural vaginal pH, especially Lubina, which has a probiotic in it, which can help with the vaginal pH, increases moisture elasticity, can reduce pain with penetration, reduce itching and irritation. But it's important to remember that even if you're using a vaginal moisturizer every 3 to 4 days on a regular basis, you should also be using a vaginal lubricant with sexual activity. Now, speaking about lubricants, this is different. I brought some lubricants to show you. I actually brought my favorite silicone-based lubricant called Uberlube, and I brought some samples here if anybody wants to take one. But lubricants are interesting because, again, when you go to the drugstore, you're going to see a whole wall of products. You're not going to know which one to get. Now, some people are going to go in their bathroom to get a lubricant, and that's pretty common. You're going to end up with a petroleum-based lubricant, either Vaseline or mineral oil. This can cause vaginal irritation, believe it or not, so this may not help. It can destroy latex condoms, so that's important to know when we're talking about using condoms for birth control or for STI protection. Some people will go to their kitchen. There is some good literature on coconut oil, by the way, as being a good lubricant. But folks will go to vegetable oil, olive oil, Crisco. These aren't bad. They're safe to ingest. They're safe with polyurethane condoms. They will destroy latex products. And then at the drugstore, the most common names of lubricants you're going to hear thrown around are Astroglide, KY, Wet. These are safe for condoms and latex products, but they dry out quickly and they can be irritating. And what I don't like about water-based is, especially if you have atrophy, you can use some lubricant. You start with some sexual activity and some friction and penetration, and next thing you know, the lubricant's gone. Plus, it gets tacky very easily. This is why my favorite is silicone-based. And these are some of the name brands. It's a little harder to find, but I'm going to show you some websites, and you'll have them with you. So if you have a computer and you like to go online, I'm going to show you 2 good websites, one of which where I got some of the products here, where you can find these lubricants broken down just like this, where you can see what's water-based, you can see what's silicone-based, or you can see what's a hybrid, both silicone and water-based. So silicone-based are a little bit harder to find, but they work so much better. They don't reabsorb, they stay moist longer, they provide a lot less, they cut down on the friction. Sometimes they last so long you have to wash them off afterwards. So I prefer the silicone-based. Now, there are some medications that can be used for vaginal atrophy. So if these 2 things fail, and they do sometimes, because sometimes we need to do more than just treat the symptoms, sometimes we need to actually treat the vaginal atrophy. At a cellular level, the medications can reverse atrophy by replacing parabasal cells with actual normal vaginal epithelium or normal vaginal cells. They can increase lubrication, increase elasticity, and normalize the pH. Now, topical estrogen is available in 3 forms. One is a cream, which some of you may know as Primary Cream, estrase cream, which is estradiol cream. It's also available in tablets, which is called Vagifem tablets. And these are tablets, but they're inserted intravaginally 2 to 3 times a week. It's now supposed to be twice a week. I don't think twice a week works. I usually tell my patients, you really need to use it 3 times a week. And it's only 10 micrograms of estrogen. And it's also available in a vaginal ring. The vaginal ring is called estring. It delivers a constant steady state of vaginal estrogen just to the vagina for a 3-month period of time. Now the ring is kind of firm. It's not real flexible. Sometimes difficult if you have difficulty with manual dexterity to get it in and out yourself. So for these patients, I tell them really hook up with your gynecologist, talk about it, and you can have it inserted in the office, removed in 3 months, and have a new one reinserted. I have removed and inserted them in the office, but they're a little bit harder for patients to do on their own because they're a real firm, thick ring, and some of our patients don't have as much dexterity to be able to pull the ring in and out, and may not be comfortable doing that. But that's a nice way to get topical estrogen. Now I want to talk just for a minute about estrogen. Any of you who know about breast cancer or endometrial cancer know that some of these patients really can't use estrogen products because their cancer is sensitive to estrogen. So it would be contraindicated to take estrogen by mouth. When we're talking about estrogen just to the vagina, the side effect profile is very different. The side effect or the risks that we worry about with ingested or estrogen or a patch would be blood clot, stroke, possibly if you have a history of those cancers, you could unfortunately cause your cancer to return, and there have been studies that have shown that. But when we're using estrogen just to the vagina, we don't have the same black box warnings that you see when estrogen is given by mouth or in a patch form. You don't have the risk of blood clot or stroke when it's delivered to the vagina. Now, whether or not women with a history of breast cancer or endometrial cancer can use topical estrogen is quite controversial. I personally know the literature very well. There's no good level 1 or really good evidence that tells us it's 100% safe, and there's no good level 1 evidence that tells us it's 100% not safe. So then you really have to have a good discussion with your healthcare provider and talk about your quality of life. Even if you're a breast cancer survivor or a uterine cancer survivor and you have severe atrophy that would only respond to topical estrogen and it's really interfering with your quality of life, then you have a good risk-benefit discussion. Overall, we have not seen topical estrogen cause a reoccurrence of breast cancer or endometrial cancer. So that's a discussion that you have with your healthcare provider, but I think it's important to talk about because women who are on oral estrogen or a patch will see that black box warning come with their prescription. You'll also see that come when you use topical estrogen. And the North American Menopause Society is actually fighting with the FDA to have that black box warning removed for topical estrogen. Now, my favorite product that I use for a lot of my patients is called Topical Dhea, which is a short acronym for a big word, dihydroxyepindestrone, which is kind of a pro-hormone type drug. If taken orally, DHEA could potentially increase estrogen or testosterone. However, the studies have shown that when using DHEA, again to the vagina, for local action for vaginal atrophy, we did not see significant increases or barely any increases in estrogen or testosterone. So this I'm using, I have about 40 patients in my breast cancer practice with menopause and severe atrophy on intravaginal DHEA, actually doing quite well. It can reverse vaginal atrophy, much like estrogen, if not superior to estrogen. And the nicest thing about DHEA, other than it doesn't increase hormone levels, is you can actually increase arousal. There are some studies that have shown in rats that this medication increased nerve fiber growth into the vaginas of rats. So Dr. Labrie, who did most of the work on topical DHEA, actually hypothesizes that this may be happening with women because women will report increased arousal and increased stimulation, increased ability to orgasm when using topical DHEA. So this has been a really wonderful product for my patients who've not felt comfortable or their oncologists have not felt comfortable with them using topical estrogen. So those are a couple of the topical medications that we have to treat vaginal atrophy. Now there's also an oral medication that was approved last year or the year before called Aspina. Now interestingly, here we go with the FDA again. They approved it for dyspareunia, which is a fancy word for pain with intercourse. They didn't approve it for vaginal atrophy, but that's what causes pain with intercourse. So this medication is FDA approved for dyspareunia. I say vaginal atrophy. This is a pill taken by mouth every day. This medication is called a SERM, or a selective estrogen receptor modulator, a lot like tamoxifen, which we use in breast cancer treatment, or Evista, which we've also used to reduce risk of breast cancer and also in osteoporosis. The cool thing about Aspina is it was shown to decrease sensitivity to estrogen in the breast, but we didn't study it for that reason, so we can't give it for that reason. They didn't really study it in the breast cancer population, so it's still questionable whether or not we can use it in patients actually going through treatment for breast cancer. I personally think a breast cancer survivor is a great patient for Aspina because it acts kind of like tamoxifen, which we use in breast cancer treatment, but it reverses vaginal atrophy because of its pro-estrogen activity to the vagina and the vaginal tissues. It did not show any problem with the lining of the uterus, which can be a problem with this class of medications. So this is kind of a neat medicine, and I've actually started using it in some of my breast cancer survivors who are several years out from their treatment. But this is a pill. So along with therapies that we're going to use for atrophy, like moisturizers, lubricants, I talk to women a lot about vaginal stretching. Some of my patients end up with me and they have not had penetrative intercourse for a year. I had one patient, it had been 10 years. When that happens, no matter what our best efforts are with medications, they may still have pain with intercourse because they need to do some vaginal stretching. One of the modalities that I talk to patients about for vaginal stretching are vaginal dilators. And this is a set of dilators, and again, I'm going to show you a couple websites where you can actually find these. Dilators start off, I usually tell patients about the size of my pinky, which is about this size, and increase. This one is a set of 5, and I like this one. I think 5 is good enough, all the way up to an average erect penis size. So what a woman would do is gradually increase at her own comfort by herself or with her partner with a lubricant. Maybe I tell patients 2 weeks to 4 weeks after they've started a medication for vaginal atrophy, because a lot of these treatments will start to work about 2 weeks after starting the medication, whether it's estrogen or DHEA, and gradually work their way up. You have to stretch and prepare to have penetrative sex if it's been a long time and you've had vaginal atrophy. So I just showed you vaginal dilators. I always tell patients make sure they moisturize before using them. Some patients use them in a bathtub. That's fine too. Water can be a good lubricant, but it may not be enough, so again, you may need to use additional lubricant. And that's a picture of dilators, but I brought some with me. I wasn't sure if I was going to remember my stuff, so I've always got pictures just in case. So along with lubricants, medications, and stretching, I also talk to my patients about vaginal stimulation. Vaginal stimulation has been shown to increase blood flow, improve vaginal atrophy, arousal, and sexual satisfaction. And when I say stimulation, I tell patients, don't be afraid. If it's culturally acceptable for you to use a vibrator or a stimulator, use it alone or with a partner to provide stimulation to your vagina. It's going to increase blood flow. It's going to help the experience. It's going to help with orgasm. Use it with your partner or by yourself. But stimulation has been shown to improve sexual functioning. We actually have studies that show this. So they did a study using a clitoral pump, and I have pictures of this coming, that increased blood flow and engorgement directly to the clitoris. This study actually prescribed Eros therapy with an Eros clitoral pump, and the pilot study looked at cervical cancer patients who received radiation to their pelvis. So they had significant issues with vaginal atrophy. They also had some scarring from radiation. They did this 4 times a week for 3 months during foreplay, either by themselves or with a partner, and they found significant improvements in sexual desire, arousal, lubrication, orgasm, and sexual satisfaction and pain. They had significant improvements. So this was a study that was done with a clitoral pump that had significant results. These are clitoral pumps. The one here is the actual Eros device. This one is patented, so this one is the most expensive, but you could get a clitoral pump that's much less expensive that does exactly the same thing. And then this is an example of vibrators. I brought a vibrator with me that's my favorite. It's the breast cancer ribbon. I tell women, find something that's going to work with your manual dexterity. If you have arthritis, maybe something larger or something easy for you to use to be able to provide stimulation. You want to focus stimulation in the vaginal tissue, but you really want to focus on the clitoris so that you can get the most stimulation to the area. I tell women make sure there's more than one speed, because too fast can be too much and provide overstimulation, and too little not enough. I tell women to make sure that it's a soft material. So that's one of my favorites, and I'll leave it if you want to see it. Now, I was telling you about some websites that I really like, and this one is called Middlesex MD, developed by a gynecologist, Barbara Dupree, who's actually in Douglas, Michigan. She's also a certified menopause practitioner like myself. This is a fabulous website. She will blog with you and answer questions if you want to ask her questions. And if you go up in the corner here where it says shopping and you click on that, that's where I got the dilators. That's where I got the vibrator. And then she also sells these really cool kits with lubricants so that you can try a set of 5 or 6 and see which one you like before you commit to buying a whole bottle of something. So I really like that. She packages everything really nice. It comes to you very discreet. You won't get pop-ups when you're on this site. It's a very reputable site. She provides a lot of good education for women. And then this one is pretty similar. It's called Sexual Wellness MD. One of my colleagues through the Sexual Health Certificate Program developed this with her partner who's a physician, and she's a nurse educator. They do podcasts. They do a lot of patient education. They also have a shop that has a lot of really nice products. I want to mention pelvic floor rehab because sometimes women don't realize how much pelvic floor rehab really can help with pain with penetration. Our pelvic floor specialists are physical therapists who actually have a specialty in pelvic floor rehab. We have folks available at the RIM, and at University of Michigan they have a wonderful pelvic floor rehab program as well. It can help release tight muscles. They actually do muscle release intravaginally. There's techniques that they do, and this really does work for women. especially when they've had radiation therapy to the pelvis or the cervix, for cervical cancer. Pelvic floor rehab really does have a role. So I'm going to move on to decreased desire, which we said was the second most common problem for women with cancer or without cancer at any age. And can anybody guess why it's an elephant? Because nobody wants to talk about it. It's the elephant in the room, because nobody really knows what to do about desire. We don't have any approved medications for women in libido. So what do we do about decreased desire? Well, what I do is I educate women. I educate women and I teach them about the sexual response cycle. I teach them that they are normal, that women are somewhat different than men, and some men are like this as well. The sexual response cycle can be very different for women, and I'm going to talk about 3 different sexual response models. One is Masters and Johnson's, and I have a picture of it. Masters was a physician, Johnson was a psychologist. They were the first ones in the 50s in the United States to really study sex. And the way they studied it was they used electrodes to women's genitalia and they induced orgasm, and they actually plotted out graphs and they measured the physiology and the response cycle of female orgasm, which was very progressive in the 50s. They were the first ones in the United States to do some significant work in this area. Folks were doing it in other countries, but Masters and Johnson really put sex on the map as far as research in the country. And then Kaplan came along, and she was a psychologist, and she said, well, we need to add desire in this sexual response cycle. It can't be just about the physiology of orgasm. We need to talk about desire. But then Rosemary Bassan really got it right when I think about women's sexual response cycle, so I'll show you these. Masters and Johnson really focused, like I said, on the 3 levels going on with orgasm and physiology and the response: excitement, plateau, and orgasm. And men and women are similar in this way in how we experience orgasm. Women, female orgasm, there is data and research that shows that orgasm for women can be very different for men. Kaplan's sexual response model, again, looked at desire and arousal and then orgasm, which makes sense. But Bassan, I think, really got it right. And when I actually hand these out to women, because when they see that their response is different and that they're normal, this is really a relief to them. So I tell women, first of all, you have to have some intimacy and relationship satisfaction. If your relationship isn't satisfactory, if you don't feel that you have intimacy, you aren't going to feel arousal or desire, or you're not going to want to have sex most of the time. And I'm talking about a population where they're struggling with this anyways because of fatigue or sexual health issues, atrophy. Next is arousal, and this is different than Kaplan's model because Bassan came along and said, wait a minute, women need to be aroused before they experience desire. And if you think about it, it makes sense. We don't walk in the door immediately feeling aroused and wanting to have sex most of the time. We're thinking about switching the laundry, or maybe doing homework with kids, or transporting kids, or maybe we're thinking about, I just got done with chemotherapy, or I got to go to radiation first thing in the morning. So they're not walking in the door thinking about it. But if they take the time, either alone or with their partner, to become aroused, desire is going to follow. So when I talk to women about this, light goes on and their eyes brighten. Oh my God, I'm normal. And they say that to me. Can I have a copy of that? Because this means so much to them. Arousal needs to come first. Sometimes we need to take the time, either alone or with our partner, to become aroused, and then we're going to feel desire, and then we're in the sexual response. And as you can see, it's circular, it's going back and forth. So I think Rosemary really got it right. Sometimes there's body image concerns for folks, and this is men and women with sexual health. It can be associated with surgery, either through mastectomy or ostomy. You can have hair changes because of chemotherapy, weight changes. I brought with me something I think is pretty nice that you can get from, and I have handouts here if you want it from, it's called Ostomy Secrets. Ostomy Secrets. Yeah. So these are kind of cool because they can provide a covering wherever you're feeling self-conscious about something. Maybe you have an ostomy from a colostomy or ileostomy. So these can make people feel much more comfortable if they have body image concerns. I talk to folks about body mapping, and this is just as simple as providing a map and showing your partner, marking in red, where they're comfortable and where they're not comfortable being touched. Believe it or not, communication means a lot. I had a patient who told me, this was before I was thinking about going back to school for this program that I just finished. She said, if I have my mastectomy bra with my prosthesis. She was a bilateral mastectomy patient. If I have my mastectomy bra with my prosthesis on, and my husband comes up behind me to touch my chest and my bras, my prosthesis, I'm okay. But if I don't have my bra or my prosthesis in place and it's just my bare chest, I'm not okay. So what would be helpful for her is if she wasn't communicating that to her partner. So that's something as easy as a body map. You know what, mark in red what's not okay. And then we can talk about it. Your partner can know about it, and you can work towards that being okay. I talked about the body coverings already. So I want to mention a little exercise called mindfulness, because with body image, when you're going through cancer treatment, when you're going through body changes that have to do with therapies for cancer, surgeries, body image concerns, one of the problems that's in the literature and patients will say is they're getting these intrusive thoughts. They're trying to be intimate with their partner, but at the same time, these thoughts are popping in their head like, I can't believe I don't have a breast. I can't believe I have this ostomy. I have a bag, with stool in it. How am I supposed to feel sexy? These are intrusive thoughts, and how do we get rid of these thoughts? One exercise that I teach my patients is called mindfulness. Mindfulness can be a way to quiet the mind. This is something you can do if you're stressed at work or there's something going on in your life and you just need 5 minutes to stop the negative thoughts. Believe it or not, negative thought work is a big trick that therapists use to try and help folks get past some of these issues. The key is to focus on being in the moment. So I'm going to do a quick little mindfulness exercise with you. This will just take a minute. Bear with me, and I want everybody to do it with me. And I'm looking at you so I can tell if you don't do it. Close your eyes. Everybody close their eyes. Okay. Now, pretty much all of us have taken a shower. So we're going to do a shower mindfulness exercise because this is something you can all identify with. So you've got your eyes closed. You're naked. You're going to take a shower. When you step into the shower, I want you to notice the cool floor of the tile in the shower. I want you to turn the water on and notice how cool the temperature of the water is right now. Now the water temperature starts to warm, and I want you to think about and picture what warm water, as it gets warmer, is feeling like on your body. I want you to notice how it feels as it hits your arms, your legs, your torso. I want you to pay attention to whether or not it's a gentle spray or a firmer spray, and what that pressure feels like on your body from the water. I want you to smell the water. What does the water smell like? Now I want you to follow a drop of water as it hits your skin, up near your shoulder, down your chest, down your torso, down your leg, all the way down to your foot. Okay, you can open your eyes. See, it's quick. It's a way to calm you. It's a way to quiet your mind. And this is something you can do anytime. And there's many different ways to do mindfulness. I pick this because I'm usually doing it with a talk. I'm usually seeing a patient. I have limited time. And I want to teach folks something they can do to stop the negative thoughts. So a lot of our folks, patients who are going through cancer treatment or been through cancer therapies have fatigue, and this can also interfere with sexual functioning. So I talk to folks about a Sensate Focus program, and you hear the word Sensate Focus thrown around in the literature when we're talking about sexual functioning, but no one really defines what it is. So I'm providing that for you in a slide that you have so that you know what Sensate Focus really is. And this is something else that I've done with my patients. I use this with the body mapping. So you're telling your partner what parts of your body you don't necessarily want touched because you're self-conscious about it, or you're telling your partner what you're not comfortable with. Maybe you're still under treatment for vaginal atrophy and you're just not ready for penetration, but you want to have intimacy. Sensate Focus builds trust, focuses on intimacy. It helps you be in the moment. God bless you. Be in the moment, like mindfulness. It's about being in the moment. It takes the pressure off of function. It's not about function. It's about the experience of sensations, just like the shower mindfulness. Being intimate with your partner is about the experience of sensations. It's not just about function. So this is a quick example of Sensate Focus. Each step can be done in anywhere from 2 to 4 weeks. I usually tell patients 2 weeks because I don't want folks to, for lack of a better word, get bored and lose hope. So I tell folks 2 weeks, 2 weeks, 2 weeks. You start in phase 1, you're clothed or partially clothed. You cannot touch zones that would not be clothed. In other words, you can touch anything that is clothed. For 2 weeks, lay next to each other in bed and touch, massage, but you have to be clothed. The next step is you can take the clothes off and you can start to touch the erogenous zones, breasts, genital areas. You may introduce some stimulation. Again, the goal is not orgasm, it is not penetration. Slow down, begin again. And then finally, after 4 weeks or longer, we get to phase 3. Then we can start with some penetration, paying attention to other parts of the body. And what's nice about Sensate Focus is for women, especially who are having pain with intercourse, maybe they're in the midst of treatment, if they get to this point and penetration starts to hurt, we back up. Because again, the focus is on the intimacy and the experience. It's not on function. So I tell patients, focus on anticipation, not spontaneity. When we were younger, in new relationships, it was all about being spontaneous, right? Well, now the focus is really on anticipation. You need to anticipate sexual activity. Do what you need to do to prepare. Treat vaginal atrophy if it's painful. Use stimulation. Use lubricants. Men, there are a whole myriad of other things that Dr. Alley will probably discuss about erectile function to prepare for sexual activity. We need to prepare and anticipate. And I mentioned function is not as important as intimacy and experience and sensations together. If you're having trouble, please speak up. I can't stress that enough. The literature shows that patients aren't talking, providers aren't asking. That's a problem. So please speak up. We'll do our part, I'll do my part to ask. That's a part of my history with patients. That's why some patients are sent to me to talk about sexual health. Ask about your symptoms because there probably are therapies for it. And I also want to share with you a quote from one of the sex therapists, Daniela Whitman, that I worked with out of University of Michigan. She's part of the prostate cancer program out there. I love this quote. Recovery of sexual health and sexuality in the context of chronic illness, cancer, any chronic illness, does not imply returning to baseline. It doesn't have to be like it was, but it can still be very good. It can be better. That's it.